Chief Gary Taylor. I'm the Public Safety Director for St. Albans.
Mark Levine, Commissioner of Health.
My name is Melinda Lucier. I'm an MAT Care Coordinator with Northwestern Medical Center and a person in recovery.
I'm Beth Crane with Franklin County Caring Communities. We're a prevention coalition.
Erin Heinlein, Granite Director of Turning Point Recovery Services.
Kathy LaVoy, Executive Director of Workforce and Disability.
Kristen Pryor, Agency of Human Services, Field Services Director, and a person in recovery.
Jolinda LeClaire, Director of Drug Prevention Policy, and I oversee Governor Scott's Opioid Coordination Council.
I'm Jill Brayborn, CEO of Northwestern Medical Center, and grateful to be on the Opioid Coordinating Council.
I'm Jason Gogan, Regional Director of BAART. I oversee the core program.
Good. All right, well, thank you. I'll just make a few opening remarks, but I want to first say that this challenge is so fundamentally something that has to be addressed at the local level. And I see the federal role as one of helping to provide some resources to our first responders, to the organizations that are actually doing the work. But there's no way that you can't address this without the fundamental engagement being it's not just the local level, it's at the individual level. And what's been so impressive, in my view, about Vermont, and I give all our governors, but Governor Shumlin, when he made this discussion the centerpiece of his address, and I remember that was well before people were acknowledging the extent of the problem. And it was a very interesting experience for me because when I was on the floor walking around, the governor's address got a lot of attention, and a lot of my colleagues came up to me and said, why in the world would the governor talk about your state and reveal that issue? And then 5 minutes later, they'd come back and they'd acknowledge to me that everything he said about what was going on in Vermont was going on in their district. And it, obviously had no partisan limitation. It was a Republican or Democratic district, and it was really, really good people. So that acknowledgement, and I think it was really helpful in having all of us understand that the only way you start to deal with the challenge is to face it, define it, face it, and be straightforward about it. And my view is that at the federal level, we can do a couple of things that we're working on. One is money. Quite frankly, we've got to get some money back to the first responders. Remember, when we were traveling around, there was a lot of demand on your force to be responding to a lot of different incidents, not just the law enforcement part of it, the mental health part of it, the physical health part of it, and the expectation can't be that we have to do that without any resources to help you back that up. So we did pass legislation that supposedly is going to have $1 billion, but the money's not there yet. Right? And that was bipartisan. It's good to say. Some of the other things we have to do is start changing the way in which prescriptions are being administered and how we deal with pain. And a lot of us are pushing at the federal level to have the National Institute of Health really double down on their research to find alternative ways of alleviating pain rather than the what clearly has been an excessive reliance on opioids. And the third thing is, this is a good thing in the Trump administration. Scott Gottlieb, who's the FDA commissioner, is really focusing on some of these time-release opioids and really looking to have very stringent prescription guidelines and also treatment guidelines because of the real significant risk that goes with that. So there is action at the federal level. Bottom line, I really do think we have to have money that gets back to our first responders, and where you've got a network of organizations like we have in Vermont, so much based really at the grassroots. That's the role I think we should play. But I'm going to stop here because the role that you have to play is the everyday reality of what this means and how devastating it is, and how much it takes the communities to be engaged to try to address it. And just again, going back to law enforcement, it's so different than in the past where there's an acknowledgement up front that there really is a medical issue. No, this is not, it doesn't, it's very difficult. Hi, Tim. In trying to destigmatize it, it's not so much to say it's the right thing to do, it's to say that the best way we can deal with this is to deal with it and not assign values to it. We know it's better. None of us like to be in the grip of any kind of addiction, but I can speak. I don't have an addiction, but I have a lot of bad habits, and it's hard to break them.
We're going to do that here.
All right.
Tell me more about that.
Should we close the door?
Well, the point is, there's got to be some appreciation that, however it is you came to have this dependence, it's not like you just need a 20-minute explanation from somebody who knows better that you'll be able to just cut it off. So I really want to thank you guys for taking it. So why don't I stop there and open it up for discussion?
Would you like us to follow the agenda?
Yeah. No, I think we should have kind of a freewheeling discussion because what I'm interested in is your input on what I can try to do federally. Okay, and there's a variety of things, and there's some in as bad as things are in Washington and they're really really bad right now. There's a lot of good people there.
Yeah.
Okay, and we're in kind of a broken system and at a bad time. But there's a lot of good people that want to help. And one of the reasons that I have been getting so involved in this is it's actually an area that so touches all of us that it's creating some potential for common ground. And if we can find some common ground here and make some progress, maybe that can also spill over into other ways of behaving on other issues that are really important to the country. We'll start with you, as our medical.
Great. I did follow the agenda, so I prepared about, I hope, no more than 5 minutes of comments because I want to make sure we all have a lot of time for discussion. And my agenda is sort of where we've been and what we're good at and where we need to go and how the federal government may help. So I'll try to say all that concisely. Because we've made, as you know, we've really made a name for ourselves in Vermont. We've made great progress in a positive way.
By the way, Governor Scott is coming down on Tuesday. He's going to
I'll be with him.
You're going to be with him, going to the Ways and Means Committee. Yeah, so that's terrific.
So, we've certainly been a state leader, especially in efforts of treatment, where we probably have the greatest fame with medication-assisted treatment, the hub and spoke system, treating this in a home health model, health home model, sorry, and as a chronic condition. And we now have a study that just came out, mostly a qualitative study from Richard Rawson that actually clearly validates that MAT works, which we didn't really need to prove, but it certainly showed that. But more importantly, it showed a lot of really excellent things about the system that we developed here. We clearly have expertise in treatment. We've met capacity, which many states are struggling with, just to find places to treat people, get them in an expedited manner. And we've done a lot with harm reduction strategies in terms of naloxone availability to anyone who needs it, syringe exchange, needle exchange programs, safe disposal issues, etc. We've had strong messaging programs targeting them to specific audiences by age usually, and the media that those ages all use. And perhaps a leveling off, but I can't promise that yet. The final numbers aren't in our opioid overdose death rate year to year should not be tremendously worse than last year, but I can't promise it will be substantially better. But better to plateau than to keep ascending. And as you mentioned before, there are things like prescriber rules prescription monitoring systems that are kind of established and in place and working for us. But having said all that, we can't kind of rest on those laurels. I always like to say this is a marathon, not a sprint. We have a long way to go. And whether that has to do with the fact that an average of 2 Vermonters are dying a week of unintentional overdose, whether that has to do with the fact that some project there are 8 out of 10 opioid use disorder people out there that are not actually in treatment or seeking treatment, and how does one find them and get them into a system that now can meet their needs pretty much instantly. And we still have communities that are suffering, and everyone knows somebody in their community in some way that's been impacted by this crisis. So Jolinda's led a wonderful opioid coordinating council, which we'll hear some results from, and we have a great report from Dr. Rawson, as I mentioned. And it's great to have forums like this. But if I could just sort of outline where we need to go in treatment, prevention, and recovery, since those are the overarching areas. I'll leave enforcement out and let others in that area handle that. So, in terms of MAT, one of the things I mentioned is just getting people into treatment that we might not otherwise have found. And we actually have some grant money through the federal government that's going to help us with a concept called respondent-driven sampling, which actually allows you to find the people who are in treatment, and obviously they're part of a larger community that you may not always have access to, of people who are suffering from the disorder, and help get those people into treatment. Alabama and Vermont are the 2 states that the Center for Substance Abuse Treatment has chosen to partner with on this. Dr. Rawson's report mentioned some areas where we could improve our hubs in. A lot of it had to do with more of the personalized experience of the hub, catering to a smaller quantity of people than some of the larger hubs, and expanding our spokes. As you know, the spoke system is primary care offices predominantly for patients on buprenorphine, and those are not always seeing the capacity of individuals they could see, or there may not be enough in certain regions of the state. We have programs to start initiating treatment in emergency departments, which has not really been done to a great extent before and should happen. Programs to embed peer recovery coaches in emergency departments, so when first responders bring them into the hospital and they are awake and often not happy about being awake from their experience that they were experiencing, that they would have someone besides the medical staff to talk with who's actually had a lived experience and can work with them to perhaps get them into treatment at this kind of vulnerable time.
Here, in a way.
Exactly. There are a lot of initiatives going on in our departments of corrections, where, as you know, people's Medicaid drops off, and essentially the state picks up the bill. And in terms of the federal government's involvement, I would say one of the things when we go to Washington we'll comment on is we're working with CMMI to try to broaden the payer pool for MAT and for the associated services, especially in terms of getting Medicare involved in funding that, since it does not do any of that. There's a program called SBAART, Screening, Brief Intervention, Referral to Treatment, which is another intervention that can be made to identify quickly and then hopefully act on what you find to get people into treatment. We've been on a federal grant that will end this year, and it would be nice to see that funding return in a more exuberant way, so practices and hospitals around the state can be further trained and up to speed on that. The whole issue of funding medication-assisted treatment in corrections remains an issue, which we're embracing, but there's no real federal involvement. And then continue to get the kind of support we get from groups like SAMHSA and the CDC for some of the programming that we do in that area. In terms of recovery, I think you'll hear from people that we have a wonderful array of recovery centers throughout all districts, but I hope you'll also hear that they're funded on a very shoestring budget and have need for much greater levels of support. We also find that people in recovery need more support than just the kind of support you get when it comes to your medication-assisted treatment and your counseling and your peer support. They also need to have a place to live that's stable, and more importantly, they need to be able to return to a life that's more rich than just treating their disorder, but involves employment, and have employers trust in that workforce pool that really is somewhat untapped, and have that pool be able to embrace opportunities that come their way.
It's rebuilding the whole life.
It's rebuilding the whole life, is right. It's interesting that whenever we think about treatment, whenever we think about funding from the federal government, it essentially focuses most exuberantly on treatment, which is, of course, job one. But at the same time, we like to refer to the kind of continuum of prevention, treatment, recovery, and so many of those other dimensions, I would say, ignored might be too strong a word, but they certainly don't get attended to
I want
with
to
the
come
same
back
degree.
to that because I believe that. I think
Yeah.
the stronger the community, the better employment opportunities there are, the better opportunities people have to go to school, the less of a choice.
Exactly.
It's a less appealing choice, but we'll hear from some.
And the last thing is just to mention on prevention. We talked about the kind of prevention recovery centers play, because that's sort of a secondary prevention. Someone who's had the disorder is now trying to make a life for themselves and making sure they are less susceptible to relapse. But more importantly, it's the next generation. School-based programs, community coalitions, regional prevention grants are really critical to this kind of work, to the proper education and really the way our society is organized to try to help them. Corollary with that is pregnant women and their newborns, and then, as you mentioned, alternative forms of pain management. And I would also list not just non-pharmacologic, but other medication forms of pain management that perhaps have not yet been discovered. So UVM faculty and myself co-signed a letter earlier this year really advocating for NIH funding for pharmacologic research for anything besides opioids. And I'm really happy to hear you're supporting that, because that gets forgotten sometimes. But then, in addition, research on the non-medication forms of treatment for chronic pain. And maybe too large an ask beyond the funding of research would be the whole issue of one can only access a management tool that usually is covered in one's insurance. So many of these integrative medicine modalities unfortunately are not covered on their insurance. So those with resources will avail themselves of them. Those without resources may get an opioid prescription. So fundamental aspects of our healthcare system that really need to change, not just write a prescriber rule that says you can only have this many pills, but maybe you don't need any pills if you have insurance coverage for another form. So I don't want to monopolize the discussion. I will move myself around. I just wanted to frame us. I'm sure there'll be lots of other input here that's valuable.
Thank you. Joanna?
Great. Thank you. So I'm Jolinda LeClaire, Director of Drug Prevention Policy, oversee the Opioid Coordination Council. And I just want to note that Dr. John Brooklyn is here because he, every time I listen to him, I learn so much about medication-assisted treatment.
Flip a chair.
Come on over.
Well, thank you for being here. He is going to come and speak about the hub and spoke model of treatment and winding the clock back 15 years when it was you started to work with other people in the state of Vermont to create the system of treatment. I've been on board for 1 year. This room exemplifies the collaborative that is really needed to turn this curve. And when the pillars of Vermont's response were outlined, and as you noted, Governor Shumlin really took that leap in his State of the State. Governor Scott picked up and said that prevention, treatment, recovery, and enforcement are the drivers of Vermont's response that must be connected. And Chief Taylor, I look at you and I think of having Commissioner Anderson of Public Safety and Commissioner Levine of Department of Health sitting on the council, and it's that connection between prevention, treatment, recovery, and enforcement. Everybody has to start to talk the same language. I'm going to divert completely, but I'm looking at Melinda, and Melinda opened up a conference on Vermont's substance use disorder workforce last April at VTC, 160 people there. It was many of you in this room. It was a mix of treatment providers, mental health experts, higher education, the director of the Office of Professional Regulation, and people in recovery. Melinda stood up and told her story. And that's really I think if there's something that I want to tee up today, is that people like Melinda, like Jill, like so many in this room who are telling the story, that is what is building a momentum of support and understanding. For people to understand that addiction is a disease, I can't tell you how many people since I've started this job I have said that to, and then I try to pull out some charts which show the science of the brain. Most people don't know that.
Right.
And they don't know that law enforcement is spending much of their time focused on prevention. So that continuum of care is powerful. I want to emphasize maybe one thing, because I think Dr. Levine gave you a lot of ideas for where the federal government can provide more support. We do have prevention messaging campaigns. However, many of them are targeted to under 18, 18 to 25, using social media, elderly population. We could use a national drug prevention messaging campaign that would resonate powerfully, because it is that continuum. And you know, how many times does it take to penetrate the message? Every time you have to run for election, it's often, and there's so much bombarding us. So we will focus on that here in the state of Vermont. We also know that a campaign costs money, and effective messaging, which is evidence-based, costs money. The council, I've passed around a number of these two-pagers. It is a condensed version of 21 recommendations which cross the 4 drivers. And when I talk about prevention, I include education and intervention. The intervention techniques to reach people living with addiction who are not yet in treatment. I mean, as Commissioner Levine said, we actually don't know how many people in Vermont are not in treatment who are living with opioid addiction. We guess. And I'm having more and more people ask me that question, and data is a challenge. We can tell you that we believe there are about 7,000 Vermonters in treatment right now. We think maybe there are 2/3 more who are not in treatment. And reaching people where they are, whether it is in a syringe exchange program, whether it is through effective intervention programs in the emergency room in a hospital, those are powerful tools. So you have a group of experts around the table here. I will just note that we so appreciate your staff who have connected with the work of this council for the last 9 months, and we are continuously receiving information about some of the legislation you have supported. If they have legs, that's fabulous. And we're hopeful, and we have to continue to do the work. It takes a lot of hands, and I'm seeing momentum community after community. I'll also note, if anybody is going to talk about community-based prevention, those models where they exist, whether they're formal or informal, Project Vision in Rutland, which Franklin County is looking to replicate a large model, Rise Vermont, which is a prevention model. if we can do more to provide some supports to community by community, region by region, to stand up a community-based collaborative, that too will go a long way.
Thanks, Bill.
So thank you.
You're doing great work. It's
a good start.
You thought you were getting time off for a
I
while.
did.
Chief?
What I would tell you is I echo the sentiments of everybody here. The law enforcement community recognized almost a decade ago that we couldn't arrest our way out of this. And that it does affect everybody. And I don't have a single police officer who works for me who couldn't tell you a story about some connection to somebody who's fallen prey to, if you will, the evils of this addiction. The other thing is I'm really pleased and proud of all of our partners at the table here. We've been working together for a while now. In about 2008, we recognized we had a significant pill problem at that time. And we started the first drug take-back program, I think, in the state. We still do that to this day. People can drop off medications anonymously. There's a box in lobby. They don't have to identify themselves. And I know that Sheriff Marcoux now is in charge of rounding up those drugs, and he tells me that we continually produce the highest weights of drugs that are being given back. So people use it. And sometimes it's not all prescription drugs. We don't make people sort it out. We don't care. Sometimes they lose a loved one and they suddenly just come to the station with a grocery bag with all these pills and they get rid of them. But this is what I would tell you that I have learned in 4 decades in law enforcement. I spent about 2 years working in the drug task force. This is a different problem than we've ever wrestled before, and it has to be dealt with, in my opinion, in all of the fashions that we've talked about here today, with everybody playing their role and everybody standing shoulder to shoulder, but it has to begin at a grassroots community level. So what happens to us here in our community is most of my officers, certainly the detectives, I can point out 60 places where they know there are drugs being sold on a regular basis or transferred within the community. But the officers are responding to their regular calls. The regular calls in this community is somewhere between 12 and 14,000 calls a year. Dispatch is handling 118,000 calls coming in to that center. So what we've tried to do, and I think police departments have done this all around the country, is we've tried to do drug enforcement work in between calls. So when we're going from one call to the next call, not only are we looking for inspection stickers and license plates and erratic drivers, but we know about those places that we need to pay attention to. You cannot address this problem 3 minutes or 8 minutes or even 15 minutes at a time. So we have a park and ride that's become infamous, I think is the right term, because National Geographic's made a video about it. And since that video came out, we've seen an increase in that sort of activity there. And we actually had a shooting incident that began up there last spring in February, well, not spring, February, that ended up coming through the city, and it was a bad situation. So we've been telling the officers for a long time, in between your calls, you got to get in there and watch that parking lot. We got to move these people along. And they can't do it. And they can't do it because their time is so divided. They have so many other responsibilities. So, thankfully, both the city and town government have supported us. I looked around the country this year and said, what do? We've had a 225% increase in drug overdoses in our community. When I first put naloxone, or the city did, in our cars, we paid between $3,000 and $5,000 to do that. So thank you that you made that available to us so that we can administer that. So I just look at these numbers here. In 2017, we had 52 drug overdoses in St. Albans City and town. 3 of those were fatal, 26 were non-fatal, and 23 were resuscitated in some way, either through the medical community or the police. That's a huge number of people. This is my only last point is we started what's called a street crimes unit, because when I talked to other chiefs around the country and looked at the models they're using, they all said you have to have a focused attention on this problem. We know the streets. Where this is happening, it tears the fabric of the quality of life for these other community members in half. We know that our crime is being driven by, we had 7 bank robberies 4 years ago in Franklin County that we worked hand in hand with everybody else on. 4 of them were in St. Albans. They were all substance abuse related. Almost every armed robbery we have, and we average around 8 or 10 a year in the town and city, are substance abuse driven. I couldn't even begin to tell you how many domestics have underlying factors of substance abuse. And one of the issues that we're struggling with in law enforcement is, how do we everybody count beans the same way? Mm-hmm. So we're being asked right now, what's mental health problems, and what's drug problems, and what's motor vehicle stuff. Nobody has figured out the science of how we're going to figure it out. So if we go to a person with a gun in the middle of the road, is that a violence situation or is that a mental health situation? And sometimes we don't know until it's over with. And we don't even know if it's a substance abuse issue. But oftentimes there are tenets connecting all of those things. But we are the tough love. So if you go to your doctor and ask for help, your doctor will help you. If you go to a counselor and ask for help, they'll help you. When I look at Melinda and the work that the hospital's tried to do, and all the rest of you here, caring communities, everybody, I know that the minute someone raises their hand, we jump in there. The trick is getting them to raise their hand. Sometimes we're the catalyst. Prevention comes and treatment comes in a lot of different forms. So what we're doing is a very transparent public attempt to focus on the problem. And we know up front that when you cast a net, you catch a lot of fish. The people we want something seriously done about, we've caught 2 of them in 2 weeks, mules we call them. The people who are trucking this stuff into our community. We got the largest seizure of crack cocaine 2 weeks ago that's ever been made in the state of Vermont. 1.25 pounds of crack cocaine. And we got it 6 hours after it showed up here. Thank goodness. And it came from a community member who gave us the tip we needed. But that's tough love. When you go in there and you arrest everybody in that apartment, there are users there that are not the peddlers, but they won't seek any help until either the court forces them to, or once it becomes public, what we see a lot is their support network, their family, will suddenly come forward and say, we got to beat this thing. We got to get you in treatment. That's when we want Melinda and all the rest of you here at the table to intervene and make sure those people get help, because I don't want to arrest them again tomorrow or the day after. Those people are writing bad checks. They're committing petty larcenies to fund their problems. If we can get those people out of the system and focus on the real bad guys, we can probably address the problem. But this is what I hear from other chiefs. We're going to do it in St. Albans. We started in earnest 2 weeks ago, and as of today, I think we have made 12 arrests. I don't know how many interdictions. We've gotten 2 mules. And we're having home invasions that are armed, where people are breaking in to steal other people's drugs and money, and they get the wrong house, and some innocent person. We have an excellent example of that happened in the city. I got the house across the street. They wake up in the middle of the night, a child, mother, and father, to this guy with a gun and a mask in their house. And he forces them to drive them to an ATM and take money out of their ATM, and then he throws them out of the vehicle and takes off. We did catch him. You know, this team is working with the U.S. Attorney's Office. They've adopted the first case that we took. That guy is a 5-time convicted felon from New York City. We just took another fugitive out of Pennsylvania off the street who was supplying in the upper part of the city. I can't guarantee you that's what we're going to get every time, but that's what we're looking for when we go out there. And the tough love is us arresting them. And sometimes knowing full well this person's as much of a victim as they are a culprit. But if they don't get help, they're part of the problem. So our intention is to get those people introduced into the system, to make sure their support networks are aware of what the issues are, and to clean up our neighborhoods, to take back our communities. We recognize that some of what will happen is displacement. So where there's enforcement, they'll go away. But they're going to end up in the communities that aren't doing this. And it's all of our job at that grassroots level. If I do it, and the police chief in the next town does it, and the police chief in the next town does it, we can do something about this. But as long as there are hiding places and nobody's addressing it, we're never going to get to the bottom of this. Anyways, I'm pleased with the support you get. I'm a senior member of the executive committee for the Vermont Chiefs. We support your appreciation. And I certainly appreciate the partnership we have here. You don't have to do this for long to figure out. None of us are the answer all by ourselves.
Really well done. Thank you, Chief.
Thank you.
Wow.
Yeah, follow
I get to
that.
follow that. You know, it's really, first off, it's really remarkable to be in this room and to have you here to actually facilitate a conversation. Conversations that have been going on, but, you know, we need to come together like this to really reflect on the problem and seeing the collective impact of the answer, both here locally and also, you know, certainly nationally. And I think as the hospital, I hear from the physicians as they come through the emergency department and whether they're in the moment of saving a life or the SBIRT. Thank you for mentioning that. I mean, funding SBIRT and the MAT, we can't lose those programs. And we need to be able to assess folks, hopefully as early as possible, to help keep them from having an incident that they get arrested or certainly having a life-saving measure. And even those life-saving measures, by the way, can be problematic. Naloxone certainly can create respiratory distress. We have to protect them in so many ways. But I think the most important thing for me to be here is that as part of the community, this is a community approach, community-based approach, and that we're wrapping around and making sure that all of our care plans and all of our interventions are interlinked very, very tightly so nobody is falling through the cracks.
That takes a lot of communication.
It's these warm handoffs. You walk them to the next door because they may not walk in that next door themselves. That may be literally or
The term is
figuratively.
warm handoff.
Yeah,
I
the
love
warm
that.
handoff. Those
Mhm.
transitions of care and making sure that wherever door they're going in, remember they might have already been in a different door and they're coming into a new door and they may be jumping doors. And the more that we're interconnected, the better that we are. It reduces duplication. We have one care plan for folks, one care plan, and we're sharing that care plan connectedly. We also need to figure out what's driving this to begin with. And I think, so I sit here on prevention in a couple aspects, and we've mentioned Rise Vermont, a community-based approach. Let's prevent it from happening to begin with by embracing healthy lifestyles and having healthy choices be the right choice. At the same time, hospitals, we're now getting into other aspects of care for total health, which is a social determinants. We need to understand people may not have roofs over their heads, they may not have food on the table, they may not have a job, they may not have transportation. Transportation is a huge barrier, by the way. We got to make sure people are getting to those doors and getting in there with support and help. We need to make sure that we're circling them the right care at the right time at the right place. Beautiful care coordination. Also, there is a psychiatric part of this, making sure we have enough psychiatric services. There are reasons that folks are making the decisions that they're making. Having the recovery coaches, and making sure that wherever that individual is, we're there with types of services available. The other thing I'll mention as well, so tight-knit, close-knit work so that warm handoffs from door to door. The other thing is education and making sure that wherever we're getting a chance is making sure that we're educating in the schools, educating each other around the table so that we can be more informed about what the issue is and that we can help folks understand it in the community. And why do we want this to be the centerpiece? Why do we want to put this elephant on the table? We're creating a sense of urgency, and communities act when there's a sense of urgency, and the fact that we're together is really a beautiful example of that. So, enforcing, we got to get on the front end of educating, treating, and making healthy choices the easy choice. And ultimately, it's the partnership and the solidarity of a community like this community who's ready to take it on and to help each other manage through this problem together so that we do have an opportunity to keep healthy people healthy and treat those that need to have the treatment and focus on the education and services directly.
It's interesting as I listen to this and see everybody here, taking on the challenge creates its own strength, right?
It sure does. Think
Yeah.
about doing it alone and then really putting this together.
Yeah.
It's almost like not in our town, not in our city, not in our county.
Yeah.
It's not going to happen anymore. We're taking this seriously.
It's
I
pretty cool.
absolutely agree.
Yeah, no, that's interesting. I wish we had a little of that in D.C.
I've
I
had
wish I
the
did too.
distinct honor of being able to work in Waterbury and in Burlington and in St. Albans. I live in Chittenden County, but this is the community in human services that always says how how do we do it? They never say we can't do it. We can't go there, but they always say, how do we fix it? How do we get together and do it? And that's the amazing thing about this community. It's just powerful.
Yeah, it is, and obviously the whole is greater than the sum of the parts.
Yep.
When you're coordinating and working together. Speak.
Okay. So my name is Melinda Lucier. My understanding is my role here is more so coming as a person in recovery as opposed to, what I do right now. And when I had spoken, it was Barbara Smaglio who had asked me to speak, and that was on, the employment piece. But, for me, I'm going to kind of put the good, bad, and the ugly out there, try to wrap it up quickly. But, my endeavors and my addiction and alcoholism, it started at a young age like a lot of people, and it started with booze, because back when I was in high school, you couldn't walk in a high school and touch the toilet top and find powder the way that you can today. So it was a different culture. It was marijuana, alcohol, and I remember there was a little bit of cocaine, and I was one of those people. I call myself out. I was judgmental, looking at those people doing those drugs. I would never touch coke. I would never do that. And yet by thinking that I'd be immune to that because I had good parents and was in a church and got good grades, all that stuff, I had that stigma in me to judge others. As years went on, I got a DWI at age 18, got a DWI at age 21, and it was becoming red flag that Melinda might have a drinking problem, and then I got introduced to opiates, and here's something that I can
How were
take.
you introduced to opiates?
I was introduced to opiates, aside from getting the wisdom teeth out, I remember thinking like how great the pills were that they gave me. And I remember having one other injury with my ribs, and I liked the pills. I went back for more. They gave me more. Then when I went back for more, they said no, they were actually going to send me to the pain clinic. And I had no idea about anything back then of what the pain clinic was, what opiate addiction was, and I didn't feel like an extra appointment, so I didn't go back. I just let it rest. When I got introduced to opiates and addicted to them was with an individual in the community that had a history in and out of jail. And I don't blame him. I make it clear I don't blame anybody who introduced me to anything, because I would have done it either way. I would have found it either way. But I ended up living with this individual. This was after 2 DWIs and trading seats on the Titanic. So I put away the booze because I kept getting caught, and now I got something that doesn't smell. And I didn't comprehend the power of when I decide I don't want any more. Okay, I'm not going to get any more. And I was sick. I was so sick. And I didn't comprehend the power of it. And the individual that I got involved with this with, it was difficult for me to even say out loud later on that 4 months after I got clean and sober, he killed somebody in Berlin, over $80 worth of crack cocaine. So it's like, wow, that person was no better or any worse than I am, but his disease spoke loud. He didn't take the solution. I did. It's not because I'm any better than him. It's that somebody got me to do that solution. But I still got 2 more DWIs after. And I worked closely with a few people in law enforcement, especially a couple of the troopers. And, the last 2 DWIs that I have, they got the alcohol. But I had done so many opiates. And, they don't have the funding to test for that kind of thing. So that's not going to be in the statistics. So that's something that I look at a lot, too. It's like this has been an issue that we can't highlight as accurately as it really ought to be because of the resources. Right. But I did end up going to Brattleboro Retreat. I did 2 visits there with the IOP, relapsed. You guys were called by my parents because I went missing with the relapse, and everybody's looking for me because I couldn't comprehend that how could I relapse after this, and yet we feel like we've got this when we're in recovery, and we don't realize how this is a day-to-day commitment and the things that we're told to do. So I relapsed again, went back to Brattleboro. Still wasn't, and that's where I was actually introduced to the needle, was when I was in treatment, and I'm not blaming it on the place, it was who I chose to hang out with, because I was, on doing IOP, but that's when I got introduced to injecting, and that's where I learned the tricks of giving a clean UA, and looking like I'm doing everything that I'm supposed to do, but yet using harder drugs than I'd ever done in my life in a way that I had never done in my life. So all those not yets of the people that I judged, and then I was that person. So I've been humbled a lot through the journey of recovery, because until I got it myself, I always looked down. And it's probably the saddest thing that I see nowadays for some people that don't understand. But I eventually went to Teen Challenge, which is a program that's not heard a lot about in Vermont, because there's one men's home, there's no women's home in Vermont. And that's a long-term 1 to 2 year minimum residential program. So I went to Germantown, Philadelphia, and it's a faith-based program, and I stayed there for 13 months. And their approach is discipline. It is discipline. And in the beginning, I had a really hard time understanding how tucking in my bed like you do in the military and rolling your clothes, if you don't do it and you can't bounce a quarter, you get work hours. And I couldn't understand how making my bed is going to help me stop from the life I was
Taking
doing.
control.
Exactly. And it's being obedient, though. It's being obedient. Even if I don't understand the rule, if I can learn to follow it and then get healthy and balanced enough to understand the rule later, if there's something unethical, exactly.
Right.
And if it's something that there is a rule that needs to be changed or there is something that needs to be done, then humbly approaching, hey, what about this idea? But not trying to disobey the rule because it doesn't make sense to me. So I got the good, thinking thought replacement, the rational emotive behavioral therapy, CBT, all that stuff. And I didn't do medication there. They don't do medication. After the last DWI, which was in 2011, I did go to Maple Leaf Farm, and I almost went on an MAT program. The reason I chose not to is because the night that I went in there thinking I don't want to be on anything, spoke to the doctor, and she did have me understanding that 1 pill a day is better than 95 or 100 a day, so I thought maybe I oughta. But that night, I was thinking, well, I really don't want to be on anything, so maybe I'll get it and sell it. So my motives were not the right motives, so I opted not to do it. I've met people that I believe it's saving their lives, and they would be dead without it. Absolutely. And I've also met some that that's not what they need. They need the teen challenge piece of it. So I think that having, with the Vermont Recovery Network and the recovery of all paths to recovery, understanding that one person might need methadone, Suboxone, Vivitrol, naltrexone. Others may not need that. There's such a combination that for anybody to assume that they know the exact treatment for each person, it's impossible without building the relationship with a person and truly knowing that person, because everyone is different. And the housing first model is huge in Vermont. We have people coming out of treatment that I experienced it last week that come home and they don't have a residence, and the homeless shelters are full, the recovery house is full. How do you encourage a person to make sure you make your UAs and your appointments and your counseling, but you don't have a car, you don't have money, you don't have transportation, you don't have a phone yet because you just got out of treatment, you lost everything, and we don't know where you're going to sleep tonight. So that's been a tricky one too, to get recovery capital, because I think the ultimate goal is not just are you no longer using illicit drugs,
Recovery capital.
but get recovery capital
Yeah,
that not only
makes sense.
are you not using and abusing drugs, but you are enjoying your life. Like, quite frankly, who wants to get clean and sober to be bored, to be miserable and bored? And no, that's no good. So how do we make sure that people are growing and have a desire to wake up every morning, have a desire to be part of the solution? Because it's not just I'm going to stop breaking the rules and not use, but
no, I mean that
get
is
back.
amazing because what I'm hearing is that you got a pretty supportive family.
I was very
You have some
fortunate.
things going for you. Pretty good student. So,
I was very fortunate.
that's amazing. There's others that don't have that support.
That's-
Still have to address the challenges.
That's where like the peer support in the community for us, sometimes Dr. White or some of the nurses or myself, we're the only people that they know that are nice to them, that give them a little bit of love and respect. However, that's a starting point, and then we can connect them with the recovery community. And we do tons of stuff. We do softball tournaments, like all these different things that a person would think, because people get
Softball.
lonely.
Basketball.
That would, yeah, we tried that. People wouldn't do it, but that's the thing. It's like we go to concerts, go to cookouts, like get people doing stuff.
Well, what I'm hearing you say, have a life.
Yeah.
Right.
There's
I
so
mean-
much credit given to the drugs that it made me have guts to go out dancing and go and do all this stuff. And it's like remove those substances, and you're actually way more fun to be around, and you remember it the next day. Like how cool is that?
Yeah. I keep going around, but it's interesting listening because I'm kind of puzzled with what to do. There's some things the federal government can do. There's some things that we can't. We can't do this. We've got to get your tax dollars back to you, okay, to help you with this. But what I'm getting worried about is that there's such a pressure on rural America. There's people are going into the cities, and it's tough in rural America, rural Vermont, rural America, and a lot of it is the underpinnings, the economic underpinnings in rural America are fraying. The commodities up here, it's dairy, but a lot of other parts of the country, all the farm prices are down. We don't have the broadband that we need in order to be able to have an economic opportunity. some entrepreneur wants to come in, they can't do it unless their high-speed broadband. And you've got to have some infrastructure. I was talking to Dominic about it earlier today, where we're starting to do the build in rural America and create that community cohesion, which you guys are, with your efforts, establishing. That's the message of, to me, in a lot of ways, of what's going on here. We've got all these people from different parts of the community, and you're coming together and creating strength. That was the Project Vision approach. But the federal policies here are not just about after the fact treatment. It's got to be about the core commitments that government and the private sector have to make to rebuilding local economies, I think. Does that make sense?
Mm-hmm.
Absolutely.
Where you go to schools and kids have options to play sports and be around good kids. So that's kind of a big part of it, because it feels so much to me, and I don't have the experience, but it feels like so much of this is a choice that people make in a sense of hopelessness that's sort of underlying. Does that make sense?
Oh, it does.
Yeah, absolutely. I
Yeah.
mean, that's what we're trying to do in our community as a
Because
community
it's not
collaborative.
fun to be addicted, right? I mean, it's not like people want to do it.
No. I mean, in the beginning, for some people, they do it recreationally, but then it gets you, and that's a hard thing. Is that
Yeah.
when people don't understand that you're not immune to getting addicted, no matter what your
it's interesting
purpose
what
for
you're
using
saying, because
is.
it reminds me a little bit when you were saying tough love. I mean,
Yeah.
some of these people you're going to arrest are not quote bad people.
Right.
But there's got to be some
Intervention.
intervention.
somewhere. I agree. You have to stop the behavior.
Yeah.
And we have to stop it, because what happens to the next generation?
So yeah, I come into it kind of twofold here. I came into this in 2003 with a phone call from another parent telling my son opiates, and in 2003.
So you were all alone.
Yes.
I mean, that's the call.
Yes.
That's
Yeah.
one of those calls a parent doesn't
Yeah,
want to
that,
get.
and he was 16 years old, and that was the beginning of the opiates in Franklin County. So it's been quite a few years that we've
Mhm.
had this.
And what was the drug? that your son-
Oxy. It was
Oxy.
Oxy. But we
We didn't even know what it
we
was.
didn't know what that
Yeah.
was. We didn't know cocaine.
Mhm.
You know, if we saw something on a piece of granite, we thought cocaine. We didn't think these were pills.
Right.
So it started a long time ago, which put me in the position to be part of the founding group parents and citizens in St. Albans who met we started in 2005 meeting, and in 2010 we opened we got the funding for the recovery center, because we thought if we could just save one person, we could just save one of these kids. That's where we need to start.
I so love that. It's like so concrete. It's not global. We're not saving the world.
Yeah, and it was just all
Oh, I
about
love
let's just we
Yeah,
can just
that's
do
cool.
this one thing. So fast forward, recovery center, and there are 12 in the state of Vermont. We're part of 9 in the Vermont Recovery Network. Last year, 21,479 visits to our center. 101 recovery meetings a month.
So the word is out.
The word is out, and recovery is blossom, and there are people that are finding their path, and there are people that are being supported. But there again, there are so many people that are in the outline area, don't know where to begin, or have failed the treatment before, and don't even know if they want to go back, or don't even know.
So
that
is
they
there
can.
some sense when people come that they won't suffer that judgment that you were talking about? That they'll be accepted
Right.
where they're at?
And so and we're basically.
And it's not like that's permission, right? There's a difference between acceptance and permissiveness.
Almost unconditional love is the
Yeah.
way I look at it. As far as them accepting new people, that's been my experience. Because we have this common experience that nobody else understands unless you've been there.
Right.
It's acceptance and non-judgmental,
Non-judgmental,
and it's
right.
not
But there's
approving what's
expecta-
happened,
it's not approved.
but it's
That's
just
right.
helping
Right.
to change that behavior.
Right.
So
So
it's
it-
meeting people where they're at.
Mhm.
And
Yeah.
it's tough love, too.
Oh yeah, it is. Well, that yeah.
There's the queen of tough love.
That's my job. we're
How's
very
your son
fortunate.
doing?
He's doing well. I mean, it's a struggle every day. It's one of those things that he'll work at every day, I'm sure. But he's comfortable. So
Yeah.
So yeah, it's been a journey, and to be part of Franklin County, we're the most fortunate because of this group of people that work together, and that's the key.
Yeah.
That's truly the key. So we're blessed.
Peter, if I can just note, the council has put forth 3 recommendations, which are all focused on recovery. And we recognize that here in the state, it's one of the things that we do well in terms of 12 recovery centers, a recovery network, wraparound supports. But as noted earlier, there's not enough recovery housing or the continuum of housing needed from shelters all the way to sober housing.
Yeah.
And sometimes it is residential treatment for extended periods of time, which may not be readily available.
Right.
So we're working with the Department of Health, and we're really thinking about how do we strengthen this recovery network. And people will throw in transportation, childcare.
Yeah.
It's the gamut of
Yeah.
things.
Yeah, maybe have Kathy weigh in at this point.
Okay. First, I'm so humbled in this room, and this is basically all new to me in the last 3 years. When I became the chair of the task force to reduce substance abuse in Swanton through their Swanton Enhancement Project, and I wasn't sure how I was going to. I put in to be the chair of the economic committee. I don't so, but when you're talking workforce investment, of course, as the director of workforce investment, you can't talk about workforce investment. So it all came together. But as the Swanton Enhancement Project, we started out with bringing Project Vision here to Swanton, and we had people attending from the state level. Chip Taylor was there, Mary was there, and it was a great event. And I know that the city has gone on to use some of those sources. We are gearing up now to go back to Project Vision, and I hope to do that sometime in mid-March. But with us will come a bigger group. CSS has weighed in, Rise VT has weighed in, NMC, City of St. Albans, Notch. They all want to go down and see what we can learn from the Project Vision team, and I know we can learn more. But for Swanton, I made only one commitment because I do have a full-time job, and this could easily become another one, is that if we became a hub of information, that would be enough for me. And so we've brought Project Vision, we brought Seeing Through the Smoke, we brought neighborhood events, we brought the movie Resilience, and all of those things that would just make our capacity in the community bigger, because we're informing everyone, not just these people in the room and the people that are in the throes of addiction. So we do that, to your point, Peter, with all of the partners. I couldn't do this without Franklin County Caring Community, without Mary over here from the state, and without Rise VT. So, and I think what we forget is that it's stretching the capacity of
Right.
every one of us are struggling to find that little bit of money so we can do one more forum, so that we can bring in one more speaker. I'm working with MVU now on their Blue and White Day with Franklin County Caring Communities in Melinda, bringing this message into the school systems at the high school level, and looking to make every month in school a healthy month, not just bring in one day, which we talk about addictions. So, on another level, I had started about 3 weeks ago working with NMC with their individuals. They contacted me, Kelly did, and Melinda regarding the individuals that are in their MAP program and their support that is needed to bring them to employment. And there are plus 400 of them. And I didn't know that when I said, yeah, we can do something. So I gathered a group again, building our capacity in the community, brought in the Workforce Investment Board, Vermont Adult Learning, CWS, Folk Rehab, Restorative Justice Center, and we came together. They've done a survey that was great, gathered the information about where these individuals are in their level of education and their level of training, whether they're employed, whether they want more training, whether they want to be employed, and then start the discussion about what the
But there's a lot
barriers
of
are.
one-on-one individual
And
interaction.
that is
that's the key,
that was
isn't it?
ultimately the point. The only way that this
So it's real, it's
in
real
which
touch.
we can find success is to develop a sustainable system and recognize that the true success comes from that one-on-one wraparound service. We need to understand every one of those individuals. I need to understand, do they need to go to Vermont Adult Learning and get some testing? Do we know what level that they are at? What is the training that they'd like to take? What do we have to give them? What are the employability skills that they need? Do we need to wrap them in as well with the Restorative Justice Center because they have things there? Do we wrap them in with voc rehab, and can they pick up some services there on some other barriers that they may have? So we've just started the work. I'm thrilled to be doing it, but it is one more
That's
thing
great.
that is tapping the capacity of my one-person team, and I know we'll tap the capacity in some way, as it has already with NMC,
Thank you.
with voc rehab and Vermont Adult Learning, and all the players that are involved in employability and pathway exploration. So again, resources. There's no easy way to say it. It just comes down to resources. And on a personal level, so there's 3 levels here. I am working with a young woman that is in recovery, well educated, had an incredible job, and lost it all. And that pathway, if I
So she had a good job and lost it. So it's a
Very,
spiral down.
very
and
good
it's
job,
tough to
exactly.
stop.
had a very good supportive
Acceleration.
family, absolutely had everything, and it was just something that suddenly blew us away.
And see, that's something that's really humbling, too, because a lot of us like to think, oh, it's not going to happen to us. It can happen to us.
Yeah, absolutely.
It doesn't
But
discriminate.
and as hard as all of us here are working, and many of you, doing it every single day, unlike me, if I didn't know Melinda to put in a phone call, there are things that we would not have gotten as for a resource.
Right.
That lady over there didn't answer her phone at 10 and 11 o'clock at night, Mary. We could not have gotten a resource. So here, I know enough about it, and yet I still can't. Finding her pathway, finding where we had to make the call next, who would the partner be, and finding her room in a bed someplace was so.
It's amazing. 'Cause, yeah, every person is a huge. It's a huge for every individual. Because any of us who have a problem are kind of stubborn. And we don't let it go. How about you?
Thanks. It's everything that's been said so far is just so vital and so encouraging to hear people talking about this issue. I did want to tag on to something that Melinda said, which was that she talked about starting her substance use in high school, and as a primary prevention coalition, we really do look at that. We look at other substances besides opioids as being the foundation for addiction later on. And so one thing that we're doing is working with our schools to identify those curricula that are those programs that are going to be useful in educating kids. But I think there's so much more to it than that. There's the whole school climate issue. There's the question of educating the educators. I think we need to do a lot more so that our school staff and faculty are bought in on this issue.
So you think education does make a difference for kids?
I think education for the adults,
think-
for the adults who work with kids is really important.
But it's not like the kids are just, kids are kids. Their
Absolutely.
judgment is not
And they will
the best.
try things, and they will, and so
But if you have, the education of the educators, you say, will help the kids.
right, and not only around substances, but around ACEs and around those issues that are contributing to the demand, the need. And on the other end, I think it's equally important that we do look at the supply. And so parents are the first source of most of the substances that kids are using.
Oh, really?
But alcohol, where do they get their alcohol? They get it at somebody's house. They don't
Yeah.
get it at the store. Medicine cabinets.
Kids will go into the medicine cabinets.
Mm-hmm.
But even
I didn't
beyond
realize
that,
that was
the young
That's why
adults
we-
that I work with, if I'm able to get them some support because there are barriers, the barriers are usually those of their parents. It's not because they're the one that is using, they're the one, it's usually them trying to rise above. They're more than just a source for the medicine.
Mm-hmm.
At the root of it.
I'd elaborate on that.
Just to work with a young adult that
Yeah.
needs support for me for employment or training or
You've got to get
education.
past the
They
parents.
have all that other support they need as well, and it's not because they've had interaction with law enforcement. It's not because they've had
Yeah.
substance abuse issues. It's because it's in their household, and they're clean of it.
Uh-huh.
But it brings such an impact on their lives in the school systems. So educating the educators to help them to understand what's that as well.
Families, we have 3 different generations, all related. It's what comes out. Very trauma induced, and it's something that hasn't been touched upon today, but trauma has a lot to do with it.
No.
That's exactly. I agree. Trauma is a big piece of it, and just to go back to alcohol for a moment, it is kind of an equal opportunity substance for kids because socioeconomics aren't a big factor in whether a kid will use or not use. It's not so much the case with opioids or marijuana. It's a little bit different, but alcohol's available to
Yeah.
the other thing, we were certainly worked with Notch and with a pharmacy in South Bureau to get permanent drug drop boxes, prescription drug drop boxes, and so that's really
So that
important.
that program helps.
It does help. I
mean,
think
it's
it gets
amazing how
people
much
to
you can get.
clean out their.
We have
Yeah.
those
But
at the
as
hospital.
Chief Taylor said, I remember sitting in a meeting with you it's
Yeah.
been more than a dozen years ago, and you said, if we've got a pill problem now, we'll have a heroin problem in a few years, and
Yeah.
you were absolutely right. And
You know, I
that's-
just want to go back to something with the trauma. That's always been the case. You know, if your parents are alcoholics, and there's a chance you'll react against it, and you won't drink at all. But the trauma stuff is obviously a serious problem. But that seems categorically to be somewhat different than this escalation of opioids.
Closely linked. And I'm going to talk about that in the Agency of Human Services.
Because with the opioids, it's got such a physiological impact. So even if you kind of you say, I don't want to do this, you don't have.
It's not your choice.
You have will. You don't have physiological control.
No one wakes up in the morning and says, I'm going to put a needle in my arm just to see what it feels like to try it. It doesn't usually work that way.
Yeah.
They usually start with prescription.
Uh-huh.
And then once they're addicted to those. And again, it's family oriented. You've grown up in a home where your gas is going to be shut off, your electric's going to be shut off. We don't have enough food today. Well, today we're going to ignore that. We're going to forget about our worries, and we're going to use the substance. So kids are.
Is that just a young thing?
That's right. Kids are handed these things.
I mean,
by
that's
their
actually,
parents, by
in
their
those
brothers.
circumstances, a kind of pro-rational choice.
I think as a parent, too, I know that on 2 occasions I was the doorkeeper for my son being offered prescription pain relief for minor
Minor.
injuries, and I was the one mom.
And all these reasons, there's such a tremendous focus on initial restraint. Such care has been taken with the magnitude of the dosage and the duration, and the probability that we have to those in the
And
house.
if I were a doctor
start
at this
to
point,
advance.
I'd be so scared to be prescribing.
Yes.
And they are.
They are
many
now.
of them
Yeah.
And
are.
working
Yeah.
with them, they are.
And
And
we're
it's
saying-
Yeah,
They're
and,
hugely
'cause the
conscientious
cure
of
can
this.
be worse than the disease.
Right.
You give immediate pain pain relief or it's grip. So there's been significant changes.
Oh,
in the statutes.
some legislated and some not.
Well, I know it
Even
was
before
first
the-
brought up. The doctors are very jealous of their prerogatives, and they want to be the ones that are deciding the patient-doctor relationship, what to do. But the evidence, I think, for the danger of these medications is so powerful that it's kind of
And it's had an impact. That evidence is had.
Sure. I'm going to just point out a couple of things. One, Melinda, I've heard your story many times. It takes a lot of courage to do what you're doing. But I want to take it a step past that and past your recovery. What you're doing in this community is phenomenal. I hear it all the time.
Swear to God.
You are a true leader in this fight, and I thank you for that. Dr. Brooklyn had to leave.
Jill? Yeah, it's good to see you. Thanks for coming. Yeah, well, thank you. Thank you, Joe.
Dr. Brooklyn just had to leave, and I want to piggyback on Joe Linda. There's 7 clinics in the state of Vermont. ART operates 4 of them right now. He's worked at 3 of them. Without him, he's kind of the innovator of the hub and spoke model. Him and I did a presentation out in California 2 years ago. California is adopting 12 hub and spoke models that are out in other areas as well. We wouldn't be here without him today. Jill Bowen, who just had to step out, which is unfortunate. We won the PRF process to put a hub here a little over a year and a half ago. And the first 6 months, when we first got it, the property that we wanted to buy got sold 2 weeks before. And it actually ended up being very well. But then we had to find another property. We found this property. We had to go through zoning. We had to go through variances and things like that. It was taking too long. Jill Bowen at the hospital, Barbara Samaglio and I reached out to her and said, could we open up a temporary space there just so we could start meeting the need? We did that. We did it in 6 weeks, and we turned it around, and it was because of
Want
her
to get
and her
something
staff.
done?
Right.
Go to a woman.
Great, great community partners.
It's Franklin County.
You know, I've had the privilege of hosting these events with Governor Scott and Governor Shumlin, and they both asked me the same thing. Jason, what do we do? What do we do to stop? All these points have been touched on so far. But I think the big one is treatment. I think treatment is it's readily available in Vermont. We don't have wait lists right now. Even in this community, we're meeting the need as it comes in. We're working with our other providers. So treatment is good. It's on the right track. Law enforcement. I think law enforcement is a big one. And what I mean by that is Chief Taylor talks about one of the biggest busts that was just made the other day. Outstanding. Great job for you and your team. I know you're stretched thin. Everybody knows law enforcement is stretched thin. But unfortunately, what happens is when they bust that one car, the other 5 get by. And there's nothing they can do about that. So more law enforcement is always needed to go after the kingpins, the mules, as you would say. Education. Education. I love your point of educating the educators, not just the youth. When I was a kid, I had a class of 9 people when I was in 7th grade. Then I went to 8th grade, and there was 120 there. We had DARE. Well, I tell you what, DARE statistics show it didn't work. It did for me. It educated me a little bit. We need more education for our youth. I think the biggest problem that we deal with right now, not so much in this community, and people might look at me and roll their eyes, is stigma. And what I mean about that is stigma. We had, Barbara Samaglio and I did an open house in the St. Albans city, and we had about 75 to 100 people show up. Not one person was there to resist us coming in here. It was nothing but open arms. We're here now. We're seeing a little bit more of the stigma. It's not so much from the average person, the average citizen. It's more from the professionals. And we always encourage to reach out and ask questions. If you're hearing something, reach out and ask questions, and we can tell you why we did what we did. My big thing to you is Medicare. Medicare is a big one. They don't accept our services right now. They don't accept the pain clinic services. The pain clinic here, last I knew, has anywhere from how many patients are you treating, Kelly?
Maybe 320.
320. We've been open.
320? Wow.
320.
Wow.
That's buprenorphine only. We've been open for a little over 6 months, and we're over 250 here already in 6 months. And one thing that's always been a discussion that I've heard it as well, and I heard there is going to be a bill introduced at your level that where Medicare, they're going to ask Medicare to cover these services. Never forget, medication is a powerful thing, and for everybody it takes time. For some people, they might be able to kick this addiction in 3 weeks, 6 months, whatever it may be. The hubs are here because we work with the people that kick this addiction right away. I'm a firm believer, some of you have heard me say this before, we all battle addiction. Whether it be biting our nails, drinking Diet Coke, drinking coffee, whatever it is. Sooner or later, it snaps because you have the supports in your life, or something changes with you, and you're like, I'm done, and I'm going to make that change. This is why we're here. This is why the pain clinic is here. That should never stop, and the biggest thing is, it should never just be a prescription. It has to go with counseling. Our counselors here have the toughest jobs in the world. And what I mean by that is they hear horrific stories, and then they try to lead them down the right avenues, getting in contact with Belinda and other people that will help them. Counseling should never go away. I want to thank you for coming here today. I think it's great that you got to see this beautiful facility. I've had the privilege over the last several weeks to travel out to New England and visit other clinics.
Mhm.
They're not all like this.
Mhm.
There's a lot of stigma out there, and you walk into this place and you wonder why people refer to them as junkies, because that's how they're treated. It's unfortunate. We don't have that here in Vermont. We're taking that away. I really commend Governor Shumlin what he did when he brought this forth.
No, I do too. It's really special. You know, you've got a person who had a real challenge and faced it. You've got the law enforcement on the other end, and the community, and just responded because something happened in their lives. Some very simple help one person.
And it has to be this way. It has to be a community, because everybody knows. If you don't know someone in treatment, you will, especially in Vermont. The first day I walked into the St. J Clinic when I took that over almost 4 years ago, first 10 people that walked through the door, I went to school with 7 of them. I was a good kid. I was kind of a nerd athlete. And it blew my mind. And it happens everywhere. It's our nurses. It's our teachers. It's our mailman.
Yeah.
It's police officers. It has no limits. It has no barriers. It can affect anybody at any time. And it's
You talk about stigma. Communities can have stigma.
absolutely.
And I think that's why Vision worked so well in Rutland.
Yes.
They were known as the president said, a drug-infested place, and drug gangs and everything. And it's like, we got to change this.
Yeah.
And their population changed.
I dealt with it the other day in northern New Hampshire. From West Lebanon north in New Hampshire, there are no pubs, there are no
No.
treatment centers whatsoever. There were 2 doctors in Littleton and said, absolutely, we don't want those people in our town.
Yeah,
They're
and it's-
here.
the
You're
numbers
dealing
are
with
right
them
there
every
anyways.
single day. It was astonishing.
Let's not
Tim,
forget
you
our
want to?
veterans
I'm sorry.
either.
What?
Let's not forget our veterans either. We have a lot of wounded
Oh,
soldiers
yeah.
That's
coming
where I go to
home.
Medicare. That's why I
You know,
Medicare. A lot
and
of them
these
have
people
Medicare.
are carrying
Yes.
post-traumatic
The Medicare
stress
thing is
disorder.
Yeah.
You know,
Medicare's no problem.
we have to think about them in the mix too.
Kim, you want to get the last word?
Oh,
You want to get the second to last word?
So I work for the Agency of
Yeah.
Human Services, and from our perspective, we have the opportunity to work with the most vulnerable Vermonters
Right.
of all. Because
Right.
they come
You
in
do.
looking for services.
Right.
And so what I would say to you is that we really are looking at the front end, and adverse childhood experiences, the ACEs, the 8 bills that we have right now in our legislature around that. We know data-wise that it's easier to take a kid and bring them up without trauma than to fix an adult with trauma.
Right.
And that most of the ills in our society come from trauma. Corrections, mental health, substance abuse, generational poverty, they all come with that trauma baggage. And so I think we really have to look at that trauma lens and figure out how to prevent trauma, and then look at resiliency. We're now starting to be able to assess resiliency in children, and we know that some kids that have had a lot of adverse trauma have really good resiliency, and that they can overcome faster.
Right, because everybody has some trauma.
Right,
I
and
mean,
everybody has some resiliency, but
Yeah.
if we can buff up their resiliency
Right.
and help them at a younger
It's not
age
permanent.
and intervene, it doesn't become
Right.
permanent. We unfortunately now have the honor of having the most kids in the Department for Children and Families Custody because of our opiate crisis up here. We've surpassed Burlington. We've doubled our staff.
Well, I didn't know that. Here in
Yeah.
Franklin County?
Yeah,
Didn't
in
know
the
that.
last 2 years, we've had more than anybody in the state. We've doubled our staff in the Department for Children and Families and Family Services to address that. And what they tell us is it's all about the opiate crisis, is why all these kids are in custody. We really, when we look at these folks, and we have the most amazing continuum up here, and we have great services providers. However, if you don't know where you're going to live tonight, or you're living in your car and your sleeping bag catches on fire, no,
So from a
Right.
federal level, we need Section 8s to move. They haven't
Mhm.
moved in over a year because we don't have
Well, the housing crisis is worse than ever.
right, and we
Yes, I
don't have a
agree.
budget, so the continuing resolution has eliminated Section 8s from moving. And
No,
so that's
it's-
caused a
it's
serious
disgraceful.
problem with
Yeah.
the backup in our shelters, all our transitional housing. What we have isn't moving, hasn't moved for a year because there's no Section 8s at the end of it for people to move onto. The other thing that goes with housing is transportation, child care, employment, and voc rehab for these folks, because many of them haven't worked in years and they need to figure out what it is they'd like to do and if they're capable of doing it. But until they have housing, transportation, and child care, they can't even think about unemployment. So we also need this tight communication you were talking about before with all of our service providers, and we need some sort of non-categorical case management to support these people, because leasing up is the beginning. It's
So
not the end.
non-categorical
Case management.
case management.
We need
means-
funding to pay for that through the Agency of Human Services, because most of our programs are, the federal funding is discrete and limited to a super narrow
Yeah,
population.
right.
And so we have all these services, but if there's not somebody to kind of help hold their hand
That makes sense.
and learn the social skills
That warm handoff.
and the ability to actually call somebody or go to see somebody,
He likes that.
they don't have those skills.
Well, what I like about it is that it's real.
It's how it works.
It's an awareness that you know, 3 steps between this door and that door is when the person's going to lose confidence. When you're going into the door and you're going in, you're nervous.
Yep. No, you're
And
scared to death.
You're scared.
Yeah,
Yeah.
exactly.
Yeah.
And
Scared
you
to
don't
death.
think anybody will understand you or know what.
Right.
And
No,
they have to
it's-
get through that. And so we have to be able to wrap people when their recovery is so fragile until it isn't anymore.
Right.
And we know that in the housing world. But like I said, leasing up is the beginning. It's not the
Yeah.
end. We have to stay with them to teach them how to open their mail, pay their bills, talk to their landlord if they're running late. All those things that the rest of us have learned how
Yeah.
to do, they don't have that skill set. And we have to have that non-categorical case management through the Agency of Human Services and all of our grant-funded providers like
Yeah.
our designated agencies
Yeah.
and different places to be able to have that really simple support and be in relationship with people and teach them how to be people and how to live their lives once
Mhm.
they're sober.
Amazing. Al, you want to say question? Yeah.
As a, both as a veteran and as a person, senior citizen, to what degree could we all use volunteers from my program?
What's your cohort?
Being a senior citizen and veteran.
Oh, see, I think that's the perfect solution. We have a lot of senior citizens that could be, should be, teaching
makes-
our kids
that
all
makes
these
sense to me.
things,
Mhm.
and we're
I mean,
not taking advantage of them.
Yeah, I
Mentoring.
don't know how you
people.
do it. 'Cause
Well,
the one-on-one really makes a difference. Right?
absolutely.
It's somebody who's taking
It
an
is.
interest in you.
Foster grandparents program is one way. It's
Yeah.
low-income
Sure.
seniors that get a small stipend to go into schools and mentor kids and read to them, and it's a great connection for both of them.
Yeah.
That's one. But there's a lot of mentoring programs out there, watershed mentoring. You work with a lot of great mentoring programs. We just need the volunteers and a way to hook them up. Our community justice centers are not represented here, but they're an amazing partnership with corrections and our community. We have 10 beds here for those really hard to house sex offenders. I sit on a whole bunch of circle of supports and accountability with the CJC. I used to work
Yeah.
for corrections, and working with those people who are here anyhow and are going to be in our community, isn't it better to embrace them,
Right.
welcome them, and teach them how we want them to act?
Yeah. Well, I want to thank everybody.
You gotta get back to us because I'm
Gotta-
unaware.
Yeah. Yeah.
And you have the American Legion, you also have AARP, which is about installing things.
Right. Well, the veterans, you know, you mentioned Chief for Veterans, and
He's just
they
made the
do a
case
lot of
statement
peer-to-peer.
why
And
it
it's only the
like
veterans
model
that talk
here
about it. You know,
what
I'm
it
not a
could
veteran,
do.
so
Right.
I just don't have the credibility.
9 of my officers are.
Yeah.
So we get that sort of peer share.
All right. Well, I want to thank everybody. It's
Well, we want to
2:30.
thank you.
Thank you.
Well,
Yeah.
you know what? It's kind of you to thank me, but you're doing the hard work. And my job is to try, frankly, to get the resources back to you and to have some deep. It's 2 things, really. One is there needs to be resources to come back and help pick up the expense. Number 2, there's got to be decent policies. Like, we're really falling behind on housing.
Free the housing vouchers.
No, we've got that. It's essential. And you know, and then third, there's got to be NIH focus on what are alternative ways ways of managing pain
I
that
love
don't
that.
have that addiction component or danger. And then 4, we've got to have economic policies that help build rural America. I believe that profoundly. And if we have those policies, then it's up to people back home to take advantage of it, to do it, to do the hard work. But if we're in Washington making your job harder because we don't have the housing support, or we're not sparing research dollars to find non-opioid addiction, then that just makes everything much more difficult. And what you know is that the community can reach a tipping point, and it's like Franklin County's reached a tipping point where it's engaged in facing the challenge, or it can reach a tipping point where people give up and there's despair. And that's a function of what we do, all of us. So it's pretty inspiring to be with you, because it's bad in D.C. It really is. And what's sad about it is there's a lot of good people that would like it to be better, and we've got to find a way to make the institution work, and policies work. We're not there yet. My job is to hang in. Obviously, in here, but it's really very gratifying for me to be clear-eyed, facing very serious challenges, not being rosy about it, but knowing that that's the challenge, and we do it together. So thank you.
Congressman Welch,
Thanks for convening the conversation.
But,